work on managing part of the responsibilities that Sharon normally does. So we were hoping that we could ask the members of the MAC if you could please put your name in the chat, and as we usually do, but I think Dory, you were going to ask if we could just go through a quick roll call and try and get attendance as quickly as possible that way. Is that your preference still?
Yeah, if I can take a few minutes to do that, Michael, that would be great.
All right, well, let's go ahead with that, and then we'll make a comment later in the meeting for people who join after this to add their names to the chat at that point as well, at about the halfway point. So go ahead, please, Dory. Thank you.
Thank you, Michael. Okay, I've got you down. Jennifer Marchant. Okay, Joey Hanna. Lisa Heaton. Rachel Craig. Michael Jensen. Brian Monson.
I am here.
Thank you, Brian. Dr. Robert Baird. Gina Tuttle. Alan Ormsby. Stephanie Burdick. Cassidy Matthew. Dr. Jennifer Brinton.
Yes, I'm here.
Thank you, Jennifer. Carlos Flores. Colleen Kenny. And Emily, I'm not sure how to say your last name, Emily. I don't want to pronounce it wrong. Zulton. Okay, Michael, you may begin. Thank you.
Okay, thanks, Dory. So for those of you who are members of the MAC, if you weren't on yet before we just went through the names, if you could just add your name to the chat so Dory can accurately record who's here in the meeting, that would be appreciated. Okay, our first item of business today is to welcome Emily. I'm going to pronounce her name Zutlin is my best guess, and she can correct me if that is not the way she wants it to be pronounced. And Emily would just like to take a minute and give you a chance to introduce yourself to the committee members if you're on the call yet. Okay, I'm not seeing her name, and the phone numbers don't give us enough information to make a determination there, so we will hold on that for a minute and see if she joins us a little later. One other item I just wanted to mention is we are exploring returning to offering an anchor location for these meetings with either our October or November MAC meeting. Those of you who would like to continue to participate online, we would still be providing that option for participation, but would just like to have the availability of in-person meeting for at least an anchor location and those who would like to participate in person. So more details to follow on that. And with that overview of the beginning of our meeting, we have our first item on the agenda is our Behavioral Health Master Plan. We'd like to welcome Nate Checketts and Brent Kelsey, who will be providing an overview of the master plan. So Nate and Brent, we'll let you take it away from there.
Okay, well, thank you. And thank you for accommodating our schedules. I know you had us on the agenda later, and we appreciate you letting us go earlier. Are going over to the Behavioral Health Crisis Response Commission meeting here in a little bit. I don't see Brent having joined us yet, unless he's on the phone. And so I'll go ahead and get started, and then hopefully he can join me in the discussion and the presentation. I see a lot of names that I don't recognize. I'm actually had the opportunity to work with the MAC over many years and was had the opportunity to be the director, Medicaid director for 5 years, and came to these meetings on a monthly basis. So it's interesting to have a little bit of a gap and then being able to come back and present on this issue. So I'm excited to be here. I really appreciate the work you do with this committee. I will drop here in the chat the overall link for you where the state has posted, where our coalition has posted the work that we've been doing related to the Behavioral Health Master Plan. And I'll be presenting here in a minute the executive summary and then speaking to the process that we went through in order to be able to develop this draft and then discuss where were next steps related to the draft. So the coalition is a group of interested individuals in the state related that have come together to discuss the direction of where behavioral health efforts should go in the state in the coming years. There's been, over the years, we've been fortunate as a state that our legislature and our executive branch leadership have valued the role of behavioral health in our state and have been willing to dedicate dollars to be able to grow and improve our resources available related to mental health. But one of the things that we've noticed over the years is that because there's been no centralized effort or plan or direction related to that, these efforts have often gone in many different directions all at the same time. And while that's led to advances in those areas, we've lacked sort of a central idea or a moving theme that allows us to make concrete progress in specific areas. And so part of the coming together of this group was a desire from the different parties. So we had the Hospital Association, we had Intermountain Healthcare, at the time was Health Now, some providers, local mental health authorities, the Department of Health and Human Services, coming together to try to create a draft plan that the community could respond to and that could be a prompt for what the state might be willing to adopt as a statewide master plan. And as a result of that work over the last year, we contracted with Gardner, in the Gardner Institute at the University of Utah. They subcontracted with Levitt Partners and HMA to help in this work. We pulled together a significant report that's available on that website and released it back in July as a draft so that individuals and groups like the MAC could provide feedback on what was being proposed as part of this plan. So let me walk you through the executive summary and then open it up for questions and we can talk a little bit more there. So in the executive summary, we talk a little bit about the problem for the state of Utah. This group is probably well familiar with many of those issues. You can see some of the stats that are cited there. Third highest for adults with serious mental illness, fourth highest for adults with serious thoughts of suicide, and many other issues that we as a state face related to our mental health. This work is part of a continuum of care that's provided related to these services. You can see there at the bottom of our first page of our executive summary that all the way from acute care to community education and services, there's a variety of different areas that we can address related to behavioral health. And this plan attempts to provide some direction and guidance across that entire continuum. As we look, if you look at figure 3 here that I'm showing up on the screen, our behavioral health system, some of the issues that were cited as we had this discussions with 30 different focus groups, 300 different individuals, trying to get different feedback from different groups. A concern about administrative burden, about what it takes to submit claims and be paid for these services, a lack of coordination across the entire system, systems not speaking well enough with each other, a siloed system, issues related to workforce, all resulting in limits on the access to care. In addition to some of those items cited here, we also heard a consistent discussion about concerns related to housing and how that impacted individuals' mental health and also how individuals with issues with mental health, how they struggle to keep and maintain housing. We Also received positive feedback during these discussions. There were some silver linings that we wanted to make sure as a group that we make sure we highlighted those. First, that we have policymakers in our state that recognize the need of behavioral health needs. We often speak about the stigma related to these services, but in general, there's been a general feeling that our state has acknowledged that there's a need here and been willing to step up and address that need. Obviously, more needs to be done. We're not saying that we've reached a place that we can say we've accomplished what needs to be done here, but significant steps have been made and it's significant interest in this area. We have a community that's passionate about addressing these needs. There's a desire to meet people where they are. We have many services in place that are leading out in the country. Our implementation of the 988 number and some of the work that we did before that became a national number. Some of the crisis outreach teams, the number of teams we have and where they're located are things that other states would love to be at this place where Utah is. Again, still have room to grow, but we have made significant strides. So in the plan, in this draft plan, what we've identified is 6 strategic priorities for the state about what comes next. The first one is related to advancing what we know about good care. So this is support the creation, innovation, and implementation of research-based interventions. The second strategy is strengthen behavioral health prevention and early intervention. So trying to get as early and as upstream as we can in the process related to people's mental health, knowing that as we get further into the more acute phases, that those are more costly, harder for individuals to recover from, and more impact on families when issues escalate to higher and higher levels of acuity. An overall goal to integrate physical and behavioral health, knowing that we've historically operated in separate systems for those services, and that people's needs don't, that an individual's needs don't get divided that way, that many individuals have both physical and behavioral health issues, and that those issues impact each other, and so the treatment needs to be more integrated to be able to address the whole person. Improving patient navigation and being able to access across the different parts of the system, strategy number 4. Strategy number 5, improve the availability of services and supports for individuals. And in particular, one of the areas that we're looking at here is related to subacute care, knowing that we have some of our higher level services and also many outpatient services, but a general feel in the community that there is a gap between those where we don't have enough services in between those to help people that are maybe need something beyond outpatient or looking to graduate or move out of an inpatient setting and needing to have something in between for them. And the 6th strategy then is expanding and supporting the behavioral health workforce. There's a great image graphic here down at the bottom. That darker blue shows in a general sense where the belief that Utah is, that we have a fair number of people in the middle of our system, maybe close to where we need to be, looking at licensed clinical social workers and psychologists, but a significant gap in the number of individuals that we have at the entry level that could be able to provide additional help in the behavioral health setting, and then allow those that are the licensed workers to be able to work across a broader population and provide services to broader groups. If they had more support from those at these entry level and frontline level community health workers, peer supports, social workers that aren't at the licensed level. And so this couples with some work that's going on with the Office of Professional Licensing that has also released a report on this area. So that's where this plan, at a high level, what the master plan looks at. If you go into the detail, so there's a 50 some odd page document that is the detailed part of the plan. In each of these strategies, we go through and outline recommendations about what could be done in the near future and what could be done a little bit further down the road in each of these areas. And so there is more detail there about some specific ideas and recommendations about next steps. Overall, as part of the process, as I mentioned, this has been released as a draft plan. We continue to look and seek for feedback from individuals if they have thoughts about what's in the plan, what needs to be changed, what should be improved. We are working with the legislature. It's likely that there will be a bill that will come out in the next session that would take some components of this plan and move them to statute. There's been a discussion about one of the ways to move this forward would be to create a behavioral health commission that would be responsible for this plan and be able to update the plan and set future priorities. And then also identifying what that commission would be tasked to do related to state strategy and related to this plan overall. So with that high level overview, I'll pause there and see what questions you have. Looks like Brent's been able to join. Brent, what would you add to that before I turn it over for questions?
No, I think you did a great job, Nate, and I'm sorry I was late. I think questions are, I'm certainly willing to help answer questions. There's a lot in this document.
Okay, members of the committee, anybody have questions? Okay, Stephanie, why don't we start with you?
Hi, good to see you, Nate.
Hello.
Thanks for the presentation. Hi. I was just curious, I know you mentioned, I'm sorry if I missed this, but I just wanted to understand a little bit more about when you talk about the stakeholder engagement process. You mentioned peer support specialists, community health workers, people with lived experience. Can you tell me a little bit more about the process by which you're factoring in like people that actually have like mental illness and severe mental illness into this plan? I know anyways, I was trying to kind of track that. I know it kind of came up, but I didn't hear like any specifics.
Yeah, definitely. And so as I mentioned, but I didn't go into the details of the group. So trying to respond to your question, I mentioned overall that there were 30 different discussion groups that were held and 300 participants in those. Some of those groups were groups that represent individuals with lived experience. And one of the pieces of feedback that we got back early in July was some of those groups came to us and said, oh, we really wish we had had an opportunity to weigh in on this. And there was a bit of a disconnect because of how long this process took. Some of those groups, we had actually talked to them last year. But because the time frame was so extended, they didn't realize that feedback that they'd given us in the last year's discussion was part of what we incorporated in this part. So we are going back through in the last couple of months and going back and meeting with those groups now that the draft plan is out to get their feedback and check in with them and say, okay, this plan is meant to reflect your feedback along with the hundreds of others that participated. Are you seeing that in here? Are there parts that you are feeling like hasn't been included? And part of that discussion, one of the pieces of feedback we're getting, or one part of the feedback we're getting, is that as we talk to groups that may not feel like they're fully represented in the system, so depending on whether it's race or minority or other status, that some of those groups felt like that they don't see themselves in this plan. And so there's been a recommendation or discussion to be more explicit in our addressing those types of issues. We came about that trying to use language like, if you can see, it might be in the more detailed part of the plan, but talking about ensuring coverage for all Utahns and making sure that all Utahns have an ability to access these services. So that was our attempt to get to that concept. Some of the feedback we received is it needs to be more direct, that we were not explicit enough as we talked through that. So that's something that we're going to be considering as we go to the finalizing the plan.
Thank you. Yeah, I would just echo that I encourage you to also be more explicit and just say that, like, I do think that process has like come up before where like there's engagement. If it includes people with lived experience, do they circle back? Like there needs to be processes and procedures set up so that we are respectful of people's time and their expertise of like their actual lives. And so I think anything that y'all have learned from this, to your point, like you might have consulted with people, but then they didn't realize a year later. But a part of that might be on the side of like those of y'all who were continually having meetings and not letting them know, right? And I realized there's like a lot of moving pieces, but that came up in the merger, it come up on Medicaid, it comes up in the unwinding. Like, we need to like have more clear processes so that we're respectful of people's time whenever they do engage, and especially because they're sharing such a vulnerable part of their lives with you all. And I think that that's something that's really important. So if there's some practices that y'all are developing and can implement throughout the whole agency and various programs and divisions, I think that would be excellent to see. But thank you. I know this is a lot of work and appreciate all that have participated in it.
One further point related to that. So I mentioned the commission, and it has been a key point as we've talked among the coalition that's been working on this plan, and as we speak with legislators, to make sure that individuals with lived experience or groups representing individuals with lived experience have a seat on that commission. So we're trying to figure out the best way to do that, and to your point, continuing those types of discussions, but that is another area where we want to make sure that carries through to the next phase of what's being contemplated here.
Okay, thank you. Jennifer, you have a question.
Yes, can you hear me?
Yes, we can. Thank you.
Oh, good. My question is similar to Stephanie's, and in perhaps trying to close that gap in finding individuals with the lived experience, there are many organizations out there who have peers who are willing to serve on those boards. As Brent Kelsey knows, I've seen him present at the Office of Substance Use and Mental Health, Utah Behavioral Health Planning and Advisory Committee. Thank you, Brent, for doing all those presentations, like with NAMI. There's Latino Behavioral Health Services. There is the Multicultural Counseling Center. There are so many options out there. So as everyone explores of how to make sure that piece of the puzzle is there are many options to choose from.
That's a great comment, Jennifer. And I feel pretty comfortable that we've reached the groups that you identified and others. But our challenge is now is to keep them connected to this master plan as it continues to evolve, and make sure that the old adage is nothing about us without us.
Yes.
And making sure that people with lived experience and people with family perspective are involved in the continued evolution of this plan. And so I think you have our commitment to make sure that happens.
Thank you. And thank you for all your presentations.
Yeah, and thank you for highlighting Latino behavioral health. Javier Alegre came in and we had a discussion earlier this week and had a chance to sit down and go through the plan together and have that discussion. So one of many groups that I agree we need to be connecting with.
Thank you.
Hey, any other questions from members of the MAC? If not, then we'll just open it up to anyone from the public in general. If you're observing, participating, and would like to ask a question. Okay, Rachel, member of the MAC, go ahead.
Hi, sorry about that. I'm driving, so I'm trying to do both. I was just wondering, has tribal consultation happened on this already, the behavioral health master plan?
So we've had discussions with different groups, but I don't know if it's gone to the Indian Health Advisory Board as part of that process. That's a good check to see if that's been in what phase, if we've connected with them. Have we gone back since we've released the draft? That's something we can check. And I don't know if you know that offhand, Brent, or if that's something.
No, I think that's a great suggestion, and and we should do that.
Perfect, thank you.
Okay. Any other questions for Nate and Brent? All right. Well, we thank you for coming and presenting and sharing this information with us. And I guess if other members of the committee or public have additional questions, then we can submit them through the MAC and get them to you for consideration.
that would be great. There's also, if you go to the link on the website, there's actually an email address on there too. So welcome to take them through the MAC, but also if you want to just submit them directly, you can follow the email address on, and actually I can just drop that in the chat too, but you're also just.
This is the Gardner Institute at eccles.utah.edu that you're
Correct.
referencing.
Yep.
Okay.
Either way, we're happy to take them either way.
Right. Okay. Thank you. We'll let you go on to your next appointment.
I'll be here till 3, but thank you for making sure we were able to get before we had to step off.
Okay, next, let's go back to first item on our agenda. I saw that Emily has joined our meeting. So Emily would like to welcome you to the MAC and wanted to give you a chance as a new member of the MAC to share a little bit about yourself with other members of the MAC and the public participating. Do you feel comfortable doing that?
Yes, sorry, I was coming from another meeting. I apologize for being late.
No, that happens. Thank you.
But yeah, just I work at Utah Health Policy Project. I'm a policy analyst, so I'm rather new. I've been attending these meetings for about a year. I'm really happy to be on as a member now. I'm not a Utah native, but I have been here for a couple years now, so I'm excited to learn the intricacies of this board and just all the policies in general. That's about it.
Okay, great. One question that we had earlier was, how do you pronounce your last name?
I really don't know if anyone has pronounced it before. It's from Latvia, and so when my grandparents came over, they added an H and an E, but it's pronounced Zeitlin, so you don't really pronounce the H.
Okay.
It's Zitlin.
All right. Well, all of our attempts at guessing were incorrect previously, so we appreciate the correct way of pronouncing that, and very much look forward to having you join us on the MAC and work with us on advising the program and the agencies. So thank you, and thank you for taking a minute to introduce yourself.
Awesome. Thank you so much.
Okay, next on our agenda, we have the Medicaid eligibility update. Michelle Smith will ask if you can go ahead with your presentation now.
Thank Michael. Can you guys hear me okay?
Yes, a little choppy, but I think maybe that was just the lines on my computer.
Okay, no, it's probably me. I apologize in advance. I'm having a bit of internet issues today. So for some reason, it's too bad. I'll ask Jennifer to please help to step in. So as long as you can hear me, okay, I will go ahead and get started. Reviewing our monthly Medicaid and winding report is what I'll start with. So for this last month, through the month of August, as you can see, our total Medicaid members are 441,153. And the number of individuals that we are keeping open during this unwinding process now at 165,802. September is our 7th month of unwinding. Okay, so you can't hear me.
Yeah, Michelle,
Give me just one.
it is really hard to hear. I'm kind of wondering if we could have maybe somebody else present.
I'm happy to hop in here, Michael. Let me walk through the update and then, Michelle, that sounds a little bit better. Just work through your computer. If it doesn't, I'm happy to hop in, okay?
Okay, all right, thank you. Okay, I'll try this, and
yeah,
I
that's
apologize.
100% better. Thank you. That's great.
Okay, I apologize. Okay, so I'll start off going down some of our bullet points on our update. So obviously we're in the month of September, which is our 7th month of unwinding. And this last month through the month of August, we experienced around 32,000 closures overall individuals. We do have, which some of you have heard us talk about this last time, met as an agency as well with our partners, DWS, to work through some strategies and course corrections as we are in the middle of our unwinding process. I won't go into those right now. Jen will plan to cover those during the director's report update, so I don't want to steal your thunder with those, Jen. And then another thing to mention here as well, and I think you have this on the agenda, Michael, on number 6 on the agenda, where you mention a letter that was sent from CMS to all state Medicaid directors on August 30th around renewals and doing renewals based off the requirement to do renewals based off of individual and not households. Jen also plans to cover that during the director's report update, so I won't go into detail on that now, but just wanted to mention that here. Another thing, just we kind of kept this piece on here as kind of a static bullet just for your information. I think there was some confusion over our dashboard data and what gets submitted to CMS. So just trying to make sure that that's very clear when you are going onto that online dashboard, data dashboard for unwinding, that it's clearly understood the difference in what we're showing there versus what we submit to in our monthly CMS reports for unwinding. Down here, and I'll pull up our dashboard here in just a minute, but just want to mention and show you guys in our last CMS report that we submitted on September 8th, we reviewed 32,963 individuals. 12,061 of those individuals stayed on Medicaid and CHIP. 333 were no longer eligible and were automatically referred to the marketplace, and 16,444 were closed for paperwork reasons, or also known as procedural terminations. So I'll go ahead and pause there because I see a couple of hands raised. I'll start with Rachel. Did you have a question?
I think Rachel's hand is just up from before and she's driving. So I think Stephanie's probably the one next.
Sorry about that. That's correct, Michael.
Okay, great. Stephanie?
Thank you. So I guess, okay, I'm trying to understand this data stuff. So Utah had 32,000 cases that closed last month, but the report to CMS showed 17,000 closures related to unwinding specifically, I believe is maybe the way that they, I don't know how, you differentiate that. So I guess, can you provide examples of reasons for these other 15,000 closures? And are you looking at those to see like if they are procedural versus ineligible, and maybe like but can we get some more like specifics about that?
Yeah, no, absolutely. And that's a great question, Stephanie. This report, again, that I'm showing right now to CMS is just based off of previous months' renewals, right, that were done. So for the month of August, this is the information that we're required to send to CMS in September for anything that occurred out of August renewals, right, that were affected. Those closures are based off of anyone who might have closed at the end of August. So we have individuals during this unwinding period that were not kept open because they were still eligible, right? They were still completing their renewals. They were deemed as still being eligible. If they had a change occur in their case situation, that would affect their case, they could actually be closed for that change. So for example, if I'm on adult expansion and I'm not, on the path of being held open because I didn't complete my review or I wasn't determined ineligible, right, anytime during unwinding, and I had, let's say, a new job reported, and that income that I provided now put me over the income limit for the program, and there were no other programs that I qualified for, it is valid that those individuals would close the end of the month, if that makes sense. So there
Yeah.
is a number of individuals who are on that path who have changes occur that can close. So
Is it the position of the department that 15,000 people had? Like, so there's procedural closures happening there as well, correct? Like you can have a procedurally, there are people that are falling off because of administrative burden on that side.
yeah, no, absolutely, Stephanie. And I think, again, some of these course corrections that I just very, very briefly touched on the bullet point, Jen is going to go into more detail during her report out at the end of the meeting. So I don't really want to take away some of the really important stuff she's
Go ahead,
going to
Michelle.
mention there. Unless you wanted to. Okay. All right, great. I didn't want to take that away from you, but I'll go ahead and mention some of those items if that's okay. So, and please feel free to chime in. So we did do, as mentioned before, a data deep dive, right? And I think this is kind of what you're talking about, Stephanie. Are we looking at those additional 15,000 people or anyone outside, the numbers that we're reporting to CMS? And the answer to that is absolutely yes. We are doing monitoring, our agency as well as DWS together, monitoring these closures and looking for, anything that doesn't look appropriate, right? And we're looking for trends, anything that might stand out, ways that we can look for efficiencies, whether it's system improvements, process improvement, operational policy improvements. Some of the things that we've talked about before, we did identify an area within the system where we were not extending Medicaid benefits when someone was attempting to complete their review, right? And we identified an issue in the system where it wasn't automatically giving that extension. We actually fixed that back in July. And, and that was done through this data deep dive. So there's several things that we've identified through that we're looking to improve. So some of them being around system, like I mentioned, as well as training to staff. And I think, Maurice, I think you're on this call and feel free to chime in, but I know, we mentioned at the beginning, Jeff and Maurice both talked about that a lot of our workforce is new to eligibility. So it's just this constant learning experience for them as we're going through this unwinding period, and all of this is really new. So DWS is really focusing in and targeting some of these things that we're finding in the data deep dive, and tailoring and targeting their training with staff every single month based off of those things that we're finding to try to look for improvement. So I don't know, Maurice, if you're on the call, if you wanted to add anything to that piece that we're working on.
Thanks,
Okay.
Michelle. I am on the road as well, so I hope that none of the road noise is transferring over through this call. Another thing that we've done, and I think that's going to help as well, we have, in addition to focusing our training to make sure our staff are aware how the closures are going, we're also including case reviews, which is something that we internally do to ensure accuracy. We have focused on specifically reviewing those cases that are getting closed to capture any learning opportunities that we need to go back to our staff. And I think that's been pretty effective. Lately or recently, our reviews have shown that we're getting better in terms of figuring out when the case could potentially close, and we're getting more accurate in that process. That's all I wanted to add.
Okay. Yeah. And Stephanie, I don't know if that helps. I mean, obviously there's a huge outreach effort as well that Jen can go into more detail. But we're looking at a lot of different ways to try to improve processes and reduce those procedural terminations.
So I appreciate all of that. I guess a couple points. I'll just try to go through these quickly, but I might have 3 questions within one. So I'd like to know if we can get that data deep dive. It's been referenced 2 months now, and I would be really interested in like some more specifics. And then I want to also just like share an example and see like how this would be captured. So I get a closure notice yesterday for no legitimate reason. I've gone through my review, went through all my review, blah, blah, blah. I have until October 10th to make my NWI payment, like $280. And I would need to miss 2 consecutive monthly payments before being closed out. And so like, there's no legitimate reason why I should be getting a closure. And so I've also heard of this happening to at least 1 or 2 other people within the last probably 30 days. And so I think that like, that's concerning to me because again, like that, I would have been like a closure that's in that 32,000 number, right? But I'm not going to be captured in the stuff that you report out to CMS because I've already passed my review. And though I did receive a closure that month as well. And so I do think that there are some real like there's either some glitches happening or there's like there's definitely some like erroneous closures happening even beyond just like the people that are following, the administrative burden, right? Like they're not able to get all the paperwork turned in and things like that. And so I would like to know like what type of like operational processes you all have set up because, some of the, one of my concerns in the data report that y'all sent us from last month's request was that if I interpreted it correctly, some of the information was like almost surfaced because we made the request. Like some of it seemed like you guys didn't already know about some of these disparities or you weren't regularly crunching some of this data because some of the data requests you all weren't able to provide between the 2 agencies. And so I guess I'm a little bit concerned about like what actually are you all doing? So whether it's like telling us more about the deep dive or sending that to us maybe for review for another time, it just would be a little bit easier. It's like trust and confidence is going to go up whenever we have some more specifics about like what you all are setting up operationally to make some improvements beyond just like the specific ones that you named, right? But like operationally, some of these things like got more attention because like of the conversations we've been having the last few months, but I feel like it would be helpful to know like what you all are doing, internally without just like, being asked for some of that data from members of the MAC.
Yeah, and Maris or Jen, did you want to speak to that?
Without diving into too much case detail, Stephanie, for those cases that you're aware that may have received what you believe is an erroneous notice, I would just like to leave my contact information. I think that's probably the best way to handle that. Reach out to me directly. I'll put that information in the chat, or if I'm unable to, I'll ask Michelle to do so because she has it. So you're welcome to contact me directly. As far as the data that you're requesting, I'll let Jen comment on that.
Yeah, I think more of what Stephanie's looking for, and I'd really like DWS to respond to this, is some of the work you're doing around like Stephanie specifically used the word operational around the staff, using the maybe evaluating like the training of the staff, for example, Maris, where the data is leading us to see that there are some errors. Like Michelle mentioned that there have been some programming things that we have been able to put in place to facilitate like a couple things that we saw in the system that weren't functioning properly. There is also extensive staff training going as well, Stephanie, to targeted areas. And I'd like Marissa to speak to that, where they are focusing on key areas where they're seeing it gets, there have been just focus areas that their team runs into as they're doing their eligibility review work. Maris, do you want to speak to that piece and then I can touch on data?
Sure. As part of this project originally, we knew, and Michelle mentioned this, our concern was that roughly about 30% of our staff have never processed in the world where closures are a real thing and they continue happening. So this was something that we were focused on initially, and we found that we needed to do some subsequent training. We have found specific areas and we provided the specific training. If you guys would like me to, I can put a small packet together of information that we've done previously too. I don't want to send that just to say these are all the things, but I don't want it to also appear like we're not be willing to share that data. So what I want to do is, if you want me to, I can put a small packet together that talks about the things that we have done and materials that we provided to staff. Jen, I can share that with you, and you can share it wherever.
Thank you, Maris.
Yeah.
I think the other piece too, Stephanie, that we had committed to last month with regard to where the data has led us. So specifically with regard to some key areas that members were experiencing problems with the enrollment application, for example, DWS has put forth some quick help videos that will be addressing some pieces of the application process that are challenging. These should be out by the end of the month. Marissa, I don't know if you want to speak to these pieces as far as some places where we've observed from the data and gotten feedback from consumers and advocate groups that there are some challenging areas, and we've built some tools to facilitate that process.
I can certainly include that in the
packet. Okay.
Review.
Okay, so that will be coming your way as well. The other piece too, and I'm going to put it in the chat, is a site that DWS did stand up on their website recently, which is kind of a step-by-step guide. I'm putting it into the chat here, but it's a step-by-step it's called Post-Pandemic Medicaid Review. But what it is meant to help facilitate some opportunities for the member to better understand, or those who are assisting, how to fill out the application. So I don't know, Maris, if you wanted to speak to that you put on the website. It has FAQs, also some questions around eligibility and things as well on that resource.
Yes. So one thing that we have been talking about for a while is what are business closures. For us, we are quite successful. When a customer submits a review, data has indicated that we're very successful in retaining managing for most of our members. So what we are focusing on is we're trying to increase education as well as resources available to customers that kind of give them a little bit more information about how to complete their review, how to look up their review. We have put a couple of videos on there that I believe they're brief enough, and they talk about, how do you find out when your review is due, how do you log on to My Case and check when your review is due, and how to submit that review. We believe that those strategies will help a population that may have been struggling navigating our process or systems and processes, but that's the intent that's behind this. Further education for anybody that we may have lost in our educational efforts previously, provide some context about how we make this easier and how we reduce those procedural closures and retain more people in Medicaid.
Maris was difficult to understand a little bit with his choppiness, but one of the pieces that he mentioned as well that is being completed by the end of the month are videos that are educational in nature and will walk through the review form in an instructional guide on how to fill out the review. I don't know, Michelle, if you'd like to give more information on that.
Yeah, I think, and again, I don't know, Maris, if you were covering that, because like Jen said, it was a bit choppy, but we do expect, to have those videos from DWS posted by the end of the month. And it's basically just kind of self-help, individuals who like to rely on My Case and the internet for help, just to help them guide them through the process a little bit easier. Sometimes it can be a little bit tricky navigation wise. And so these videos are being crafted right now to try to help explain the process and how to navigate the review. And it might also include the application. Jen, I know that was one question. I'll let Maris, I don't know if you can speak up to that, if it's just the review or if it's the review and application.
Yeah, at this point, it's review only, Michelle. Our intent is on retention, and we're focusing on reviews to start with.
Yeah. Okay. Perfect. Thank you.
I do apologize for stopping us. I understand Beaver area is not the best for reception, but that's where we're at. I do apologize again.
Stephanie, did that address some of your question? I think we have some other work. I know you asked about how we're using the data to guide our work. And in a portion of what I wanted to present had to do with our communication and media campaign that our public information officer and our communications team at DHHS have been working on and will be releasing in early October. And if you'd like me to go through that now, Michelle, if you don't mind, Michelle, maybe I'll just share my slide quickly to address Stephanie's question in this area around specifically.
Yeah.
Let me walk through this, Stephanie, because I think your concern around what this data revealed, that there are some targeted areas that are certainly different demographics, different areas, communities, languages, things like that, that had higher disenrollment rates than others. And some of what we are standing up right now and getting ready to release, some pieces of it are already on our website, but more is coming after October 1st, is that we are using funds from the Children's Coverage Outreach to target families who need to complete a review, specifically targeting unique groups. But broadly, there is a broad communication strategy that's going to look at billboards, social media and post ads, material distribution to community partners. And you see all the partners listed here: rec centers, WIC, Food Bank, YMCA, Boys and Girls Club, youth sports associations, churches, school districts, charter schools, okay? We're also going to be putting out radio ads, direct mail, working through communities events. We've also, and I want to point out that what we're recognizing around procedural closures, there is a gap in a person understanding that maybe there is a gap in understanding what unwinding is and what is happening right now. There may be a gap in the person not being able to understand the review. Maybe they aren't, hopefully they have their address updated. If they're receiving a notice from an email or mail source, what do I do with this review? Through this outreach mechanism, we're hoping to raise awareness again, and really put efforts around the response to those notices and updating addresses and making sure that the prompts on these medias are looking at the time sensitivity of this nature. We also saw that there were language areas where certain languages were impacted more than others. When people reported primary languages, we've noticed higher rates of disenrollments. There is going to be a toolkit of flyers that will be released in early October with all the following languages listed. This will be available on our Unwinding website. Again, one of the piece with this broad awareness campaign is actually taking it also to another level with regard to frontline staff. And this is something we've talked about with several advocacy groups for a time with our providers, and we've worked internally to really bring education down to the frontline staff. We do have awareness at a certain level, but we need it trickling down and moving down, not just trickling, but moving down to where individuals are interacting in their community, in their medical centers, whether that's at medical offices and hospitals. We are standing up a comprehensive training program where we can do an educational outreach around the basics of what is unwinding, how can you help a Medicaid member, and help navigate them either to the steps that they need to take, and to know when their review date is and what to do and to act on those things, the resources they need to get into my case or to look at when their review date is or how to complete their application. So these things will kind of be coming up in parallel, is these resources of awareness, but educating the front lines. We just put together this past week an education for pharmacists. We've received reports that Medicaid members are learning at the pharmacy that they are no longer enrolled in Medicaid, and pharmacists are going to be having a distinct training that's going to be delivered to them in a continuing education format, so that they actually get some continuing ed credit. But this is going to launch also in early October. In addition to this communication and media campaign, is moving out and working with our community health center, our community health workers that were part of our COVID response. We're going to recruit these CHWs that are in our local health departments or community-based organizations to, again, provide them, again, with a refresh of training. We worked with them a lot moving up to the unwinding activities, but really doing a refresh of training. And we're working with our folks internally at DHHS to stand up on appropriate training so that they can facilitate and continue to assist on the front lines. And I would think we hadn't mentioned this yet, but another piece around really closing the gap on procedural closures is an item we talked about last month, but it's actually been, it's gone live now. And it's a very important piece that will not just be for unwinding, but has longevity far beyond this, which is automation of our systems. So there's this piece that DWS has been able to look at ex parte automation, where automating aspects of the renewal process and being able to bring in the available information so that the system itself can automatically determine that person's eligibility. That programming went live this past week, and it will be in effect for the reviews that are occurring in October. I think the outcome of what we've shown with testing is that 13% of cases for October can be reviewed through this automated process. So when we look at, and I know you asked specifically about data, we're trying to build up our resources to target, first of all, the resources we have internally to facilitate timely access and care in media formats that are useful for members, and we need feedback on this, but also to equip our front lines so that when someone walks up to a pharmacy counter or when someone actually walks in to the emergency room or into even their dental office, that the front staff is aware and is able to assist members. And then on the back end, working with our own staff in continuous process improvement, training exercises, doing quality controls, and then using automation here where we can. So that's the piece I really wanted to cover on unwinding during my part. I don't know, Stephanie, if you have anything more to ask or if there are others, but.
Thank you for sharing. And I want to make sure that, I think Lisa had her hand raised. I do want to make sure that she can ask whatever questions she has. I guess I would just say, I appreciate all of this. I think where I feel, and I apologize, I'm going to get emotional, but I feel like frustrated by how far along we are in the process before some of these things are getting done. And I do appreciate both agencies and the efforts that you're making, but I've shared this story with some of you, and I don't do this lightly, but you know, I mean, a case manager told me about a client of hers who passed away because he did not get treatment to a very treatable illness. And he was on the street and he got a Medicaid closure and his phone died while he was trying to get through to DWS. And at the time he gets to the hospital, which he got to the hospital because his friend pushed him in a shopping cart from Redwood Road to the University of Utah Hospital. And he gets there and he isn't able to he passes away. He's 28 years old. And I keep thinking how frustrated it is to think that so much preventable problems have happened before we are dealing with it, before it happens. Like, we all knew that the unwinding was going to happen. Like, some of these ideas, like, I know that they have been shared a year ago about like community health worker training. Like, some of these things, I'm so grateful for them. Media campaigns, all of these things have been brought up quite a bit my entire time on that. And I just feel like, you know, and I don't know how quickly y'all started seeing the disparities, but like, none of them are surprising in the sense that like, we already knew that those were some of the problems. And I'm really grateful. And at the same time, I just keep thinking like, you know, you've got one young man on the street who's willing to push his friend in a shopping cart, 15,000 steps. And like, we have to go the extra mile because people, it actually is harmful for people to fall out of coverage. Like, there's treatment they cannot get. There are problems they will not be able to get addressed. And I know that there are some people that are fine if they like are in the churn or whatever it's called, but like, there is actual harm. And I sometimes just feel like, why does it take over halfway through this process before we are doing some of these things? So thank you. I am grateful. And also, like, I need you all to hear me when I say that there are people that like, it just like matters, you know, it matters for people to be able to take their kids to the doctor at 43,000 children. Losing coverage is just what breaks my heart. So anyways, I just like to say all of this. I appreciate y'all, but there is harm and I need things to be done faster because people are expecting things. It's like also not because it's out of the goodness of anybody's heart. It is a legal right for people that are eligible for benefits to get enrolled and stay enrolled on the benefits that they are eligible for. That is, there are federal and state laws that make it so that that is the law. It is a protection. There is no right to take away benefits from people who are legally entitled to them and they meet eligibility criteria. And so anyways, I just feel like I appreciate all of it. And at the same time, I just have to share that like, this is like not just like, there are actual people on the other side of this. And I know, anyway, thanks for all of the work you're doing, but like, I wish it would have been done. I wish it would have been done ahead of time. And that's just where my heart just hurts. But I do appreciate all of the people that are working hard.
Thank you, Stephanie. Jennifer, you have a question or a comment?
Yes, can you hear me?
Yes.
I just want to, trying to find the right words. Stephanie's comments, they are so important. I have been a mental health advocate for 15 years. Tomorrow will be my 15th anniversary. And as Stephanie says, the people that I know who have been lost is ridiculous. The people, they were often young. They had promising futures. One of the great ironies is I lost a friend of mine who was on the verge of graduating from grad school to help with the workforce shortage in behavioral health when he lost his life because of access to healthcare issues and access to funding. And that will change your life permanently when all I can do is decorate this person's grave, who should be out helping improve the situation as a professional himself, on which he was on the verge of becoming, and so many others. Over the course of 15 years, they were brilliant, they were talented, they had medical conditions. That was it. They had a medical condition. They needed access to health care to survive. That was all. So when people can't get access to that, we are losing so much. It's not just some other punk on the street or whatever. It was a kid getting ready to graduate from law school, someone who was going to become a healthcare professional themselves. And they did everything they could in their power to achieve that. So, Stephanie, I know you apologized for saying I'm going to get emotional. Don't apologize, please. I come at it more with a sentiment of irritation because I can't bring these people back. And the world was a better place with them in it. And they would have made the world a better place for so many people, for generations of people. So, Stephanie, thank you. Please don't apologize. And I'm just going to leave it at that. Thank you for hearing my comments.
Okay, thank you, Jennifer, and thank you, Stephanie, for your comments. That is very meaningful feedback that we all need to hear and value. Lisa Heaton, you had raised your hand earlier. Just want to make sure if you still had a comment or a question, we give you a chance to comment before continuing.
I think I got a little past where I was going to make the comment. I just had a question about just as from an organizational perspective, when we're working every day to help these people with their Medicaid. It looks like a lot of our clients are losing their Medicaid because the things that they always had to do before COVID, they didn't do during COVID, and now they're having to do again. So it's taking a lot for us to teach them and let them know that it's serious, that they've got to get the documents that they didn't have to do before, didn't have to review before. So some are losing their Medicaid, or their situations change, so they're on the wrong kind of Medicaid. And I just wondered, when they lose their Medicaid, but we start them and switch them to another Medicaid. So it looks like they're losing their benefits, or they look like they're being closed, but they're really not being closed, right? Because I mean, they're being closed and they're counted as a closed case, but then we're getting them back on Medicaid. So I think sometimes the data looks like all of a sudden there's 30,000 people with no health care, but that hasn't been my experience. Like, we're not having too many people permanent, like we're not running across cases that with the populations that we see, we're not running across cases where people just were on it and didn't deserve it, or they didn't fall in that category, or it seems like it's more logistical. So we are seeing a lot of cases closed, but then we're able to fix them and reopen them. And I just wondered, so I think that that isn't necessarily stand for a person that no longer has benefits. It's someone who's learning the new process.
Okay. Yes, Jen, if you want to comment on that, thank you.
Yeah, if I could just comment to Stephanie's presentation, and I want to just thank you, Stephanie, for sharing that story, as tragic as it is, just bringing that to the front of the work that we do. I do believe in these meetings, we often present lots of data and we go through charts and figures and numbers. And there's this person behind every single data point that is there. And I just wanted to say thank you for that. The person is very central to our work. We have done a lot already. We will do more. We've committed to doing this. And I recognize that this feels like we are putting things in place as we are halfway through. But I will commit, and I know Maurice has his hand raised too, and we say this together, that we will commit to process improvement in this area. And this is why we're displaying these steps for you today. But I just wanted to let you know, Stephanie, thank you. Thank you for sharing that story and bringing the member to the center of the conversation.
Great. Thank you, Jen. Maurice?
I just wanted to kind of respond in the same vein. I hope that there's an understanding that a lot of us that have chosen this as a career have also deep concern for the customers that we serve. As a result, I believe both on the EHHS side and DWS side, we have driven ourselves to exhaustion to do some of these things. For example, the ex parte renewals that Jennifer has spoken about should have taken 2 years of development, but we committed to 17-hour days. We have committed to overtime and testing to deliver this. Your concern and your passion for service is not lost on us. Even though we may appear like bureaucrats sometimes that have to follow rules, that is the case. We deeply care about those that we serve, and if we can do this, make this process better, I believe you heard Jennifer commit to that, and I'll share our commitment as well. We are more than willing partners to make this a better process for everybody.
Right. Thank you, Maurice. Thank you, Jen. Okay. We've had a good conversation here on eligibility update. Next item on the agenda we have is the unwinding flexibilities. Also, Michelle, with you, if you're ready to move to that, and recognizing we're a little behind schedule by about 25 minutes. If you could just focus the discussion around the items that have changed since our July-August meeting and highlight there and where the implementation is, I think that would be most beneficial to the discussion. Thank you.
Yeah, absolutely, Michael. I'm working on displaying this. I'll give it a minute. All right, so hopefully this form looks familiar to you all, or document. This is what was shared in, I believe, 2 months ago in the MAC meeting originally, and the request was that we bring this back and give some better explanation as to the flexibilities or strategies that we are planning to adopt and the ones that we are not planning to adopt and why. So we put this together, and as you can see, and this should all have been shared with you by Sharon in the email that went out. So hopefully you all have it in front of you. And to your point, Michael, I'll try to stick to the items that were discussed in last month's meeting and what has changed. So down here on number 12, I will start here. So we did seek approval from CMS for this flexibility through the 1902 E14 to permit managed care plans to provide assistance to enrollees to complete and submit Medicaid renewal forms. We were approved for this strategy on August 4th and implemented on August 14th. We've worked very closely with our managed care plans to put together some talking points for them to help assist our members, as well as a couple of videos that DWS worked on that are really great to help kind of guide through the process for an individual who is completing a renewal online through my case or a paper review. So this is one that we're actually excited about in, giving more, I guess, complete information to our managed care plans on individuals who were not successful in being reviewed through an ex parte process and were mailed out a pre-populated review form. So we think this will be a big help. The next one that I will focus on is number 13.
Let me just ask a question.
Sorry, Michael.
On that, Michelle. So I was kind of curious on your implementation date, because it seemed to me from the ACO standpoint, they didn't have training until like the 23rd or 24th of August. So I'm curious what you viewed implementation as having been met on August 14th.
Yeah, no, that's great. That's a great question, Michael. And let me clarify. So we did get the approval. We did get the data, the report created with DWS leading that effort. Unfortunately, we were late. This was our plan to implement in the month of August. So I should have updated this date. So thank you for pointing this out. We did get the data over to the managed care organizations, but it was later in the month of August. So unfortunately, we missed the time period in order for this to be effective for August. However, this did go out for September to the plans, and hopefully, the outreach that occurs with that is helpful for our members, and seeking further assistance from the managed care organizations in completing their reviews. So, thank you for pointing that out, Michael. Yeah. Okay, so on number 13, the next one is new as well. Permit the designation of an authorized representative for the purposes of signing an application or renewal form via the telephone without a signed designation from the applicant or beneficiary. This one was also through the 1902 E14 authority. We received approval from CMS for this on August 31st and put this in place and implemented on September 1st. So our DWS eligibility workers were trained about this, and this form is live and available for those individuals who may not have the ability to go online and fill out the review and sign it on their own, and may need to rely on an outside agency or someone to help them and gain that verbal signature utilizing this form in order to complete that review and get it submitted timely. So we felt this was important. We actually used this similar strategy during the PHE. We used it just for applications during the PHE. We did have a lot of interest expressed to us from agencies such as Aging Services and others who wanted this form available for those individuals who they were not able to see in person but could help over the phone with their information. So, yes, Rosemary.
Representative Lesser, go ahead, please.
I am sorry. That was an inadvertent tap. Sorry.
Okay,
Okay,
no
well,
worries.
we'll give you a mulligan and we'll put you right on notice there. Very good. I have a question. If you could go back, if you're done with that one, back to number 6. I think that's one that we had discussed as the departments were considering it, but as I looked through the document, you decided not to do it because of programming, but just to tie the loop on where we are in terms of following up from last month's discussion.
Yeah, no, absolutely, Michael. So this one was brought up last month as a strategy or flexibility that we were considering. So I'll read what this was. So renewing Medicaid eligibility for individuals with only Title II or other stable sources of income, such as pension, without checking required data sources. With further investigation, as we were looking through this strategy and the system work that we were doing to automate ex parte and how that functions in our system, this would require additional programming. So, as we discussed this, our agency, along with DWS, we determined it wasn't feasible at this time to implement this strategy. It would have delayed our implementation of ex parte automation, and we do see a great benefit with that automation. Jen mentioned this previously, and I know Maurice has the up-to-date statistics on this, but we believe we will capture roughly around 13% of our individuals each month through the automation process. Am I saying that correct, Maurice? I don't know if Maurice is in an area.
I am still here. Can you hear me? Yes, we are expecting 13%
not.
per month. Okay.
Okay,
so we're
yeah,
thinking
so
about 13%
basically with
of
this one,
monthly reviews. Okay.
for the automation piece. So basically,
Yeah.
10% of those will be taken away from workers, and yeah.
All right. And
sorry,
at
Michael.
the end of your review of these flexibilities, if you could just speak to that, because I know that was brought up as something that was in the works and just where we are on the status of that implementation as well. But I'll let you go back to your presentation.
Okay. Okay, perfect. I will do that. So then just continuing down here, let's see, 1213. Those were the additional flexibilities that we have added, and the one that we did not add from the last month that we met. I also added at the end of this document as well, just to mention some of these flexibilities that we did take up earlier on last year, prior to unwinding starting through the state health official letter. And these, for some reason, these flexibilities were not mentioned on this new document that CMS provided in June. So I've added these at the bottom of the document just for reference. Okay. So I think I'll pause there, Michael, if there's anything else.
Yeah, I had from the July meeting that your current item number 17 was under consideration, and it looks like you've implemented that now. So that looks like a new one as well to just acknowledge for the group in terms of reviewing that. It does look like, as I remember, yeah, it's got an August 2023 implementation. So that one seems like another new one that you've adopted that I just want to highlight for the MAC and the public in terms of your implementation.
Yeah, no, thank
Okay,
you. Thank
does
you for that.
anybody
I
else
did
have?
miss skipping over that one. So thank you.
Sure. Okay, any questions from members of the MAC on the flexibilities? Okay, thank you for that, Michelle. We do appreciate you putting it back in the same format so we could follow a little more easily where we were in July and what changes have been made so that we recognize the progress that's being made there. And I think when we had met in July, we were looking at 5 of the flexibilities having been adopted, and now we're at 10. So I think that shows some good progress, recognizing flexibilities don't always turn into immediate performance improvement in terms of the overall numbers, but it at least shows we're looking at things and adopting flexibilities to try and make it as easy as possible for different populations that could be impacted in the process. And so if you could just kind of speak to the adoption of the ex parte programming and where we are on that, because that seems like a big hitter type of an impact in your programming changes.
Yeah. Yes, absolutely, Michael. So, and Marissa, I'll speak to it and feel free to chime in. So basically we, obviously recognize to help improve procedural terminations and capturing individuals that truly are eligible and helping them to maintain that eligibility is to increase our ex parte renewal rates, right? And ex parte meaning, the member doesn't have to participate in the renewal. That's all done by the agency. Today, it's a very manual process. So we met with DWS and looked at ways that we could automate our system. And we're really happy about what we've come up with in terms of automation and feel like it's going to be a huge help to our members as well as workers, as well as, allowing eligibility workers to focus on those cases that might be a little bit more complex and not able to be renewed through the ex parte process. This will allow them more time to focus on those cases and give more time and attention to those. And this went in to our September release, so on September 9th. And this will affect our ex parte reviews that we look at this month. And the reviews are actually November reviews for December benefits. So those tasks that usually come across to workers starting actually this weekend will be first. The system will run through rules, see who they can update first through the process. And then anyone who the system might not have enough information to do so will actually still kick a task to an eligibility worker. And that eligibility worker will still at that point in time attempt to complete an ex parte. So it's kind of a double catch that we've created for this first phase. We have come up with at least 2 phases. There may be 3 phases of the implementation that we do. I don't know, Maurice, is there more that you want to add to that?
Yes, just one other thing. Today, and Michelle started explaining this process, when we realize an ex parte attempt is required, a worker will today get a task to attempt ex parte, and that'll happen on every single case that is due for renewal. What the system actually does after this weekend is the system attempts to look at all the data elements that are available to the system and make what we consider an automated decision of the redetermination. That is what Michelle talked about in cases. A system will automatically, without any worker or customer intervention, be able to recertify the case for another year in most cases. What happens in the remaining cases or remaining tasks, it also makes the completion of ex parte easier for those cases where even automation was not possible, meaning it will give worker information about what we were not able to complete systemically as part of the automation process, and perhaps even speed up the process of manual ex parte renewals. So that is phase one. And then, like Michelle and I talked about, we had a lot of conversations about how much further we can take this, and I think there's additional possible opportunities for us to one, reduce tasks for the worker and allow them to focus on those decisions they can make. But those things are going to have to wait at this point for implementation. But I think that even phase one, not only will it help 13% of people who will be automatically recertified, but it'll expedite decision-making abilities for eligibility workers on the remaining cases.
Right. Very helpful information. Thank you. I'll just point out that in the chat, Stephanie asked a question about whether this ex parte review would allow individuals losing eligibility from one Medicaid category to be transitioned into another one. And Michelle has answered that yes, that would work. And okay, so let me just make sure I understand this to summarize for those of us on the outside. The programming was put in place roughly 2 weeks ago, but it will only benefit individuals whose termination would possibly happen for December benefits.
Yes.
That is
So
correct.
the purpose of ex parte, right? Yeah. Sorry, Maris, go ahead. If you're,
Either one of us.
yeah. Okay. Yeah, that is correct, Michael. Yeah.
The program is available for ex parte tasks that are being created now. Unfortunately, in order to do ex parte, we have to do it ahead of time. So the reviews that we can affect at this point are the reviews that are November reviews for December benefits.
Okay. Yeah, I think that's just helpful for us as we're looking at numbers. If people were looking at the numbers coming out for October issuance and thinking there might be an impact, might be disappointed if there wasn't some change there. But I think as we look at the December benefit issuance, that's when we could possibly look to see a noticeable change in the numbers. So just wanting to make sure everybody's aware of when we think the impact would happen. So thank you for the explanation there. Okay, Stephanie just submitted a question if this applies to all members or just ones held open.
This is for all
Michelle,
members.
all members. Okay,
This is
very good. Well, thank you. That's very encouraging. We think that's a definite step in the right direction and hopefully can help your workers focus on cases that need a little more hand-holding as opposed to the ones that we think we've got enough information to process as given the information. Okay. Any other questions from members of the MAC on that topic before we let Michelle sit back and enjoy the rest of the half hour of the MAC? Okay, Davis Moore has a question.
Just a comment. I just wanted to thank you guys. I feel like you heard everything that we asked you to do. And I can't believe you're able to actually get it done within a month, maybe 2 months. And so I feel like we're lucky to have such talent, and we're lucky that you heard what we said and you took us seriously. So thank you so much.
Great comment. Thank you, Davis. Yeah, that's some really good progress and good work. A lot of challenges for sure, but definitely appreciate all of the improvement. Okay, next item on the agenda, we have just an update on the MAC letter that we sent to Tracy Gruber, the Executive Director of the Department of Health and Human Services. So for the members of the MAC, they're aware of what the final letter looked like. I noticed that it was not sent out with the meeting materials for this meeting for people to see, and I'll just ask that Sharon or Dory post that to the MAC website so that we have that out there. But the executive committee was invited to meet with Tracy as a result of the letter. I think we had a good discussion. We talked through the specific provisions of the letter with her, and Jen was on the meeting with us as well. Talked about more of the experience that people are having. Stephanie had given a lot of visibility to some of those issues in our meeting, and we tried to raise the awareness from what was in the letter to some more detailed impact. We brought up some of the specific things that were discussed in our last meeting about trying to establish a benchmark for wait times for people to get through, possibly looking at scheduled appointments as opposed to just depending on the callback wait time. Overall, I think very positive discussion, and Tracy and Jen both acknowledged that the feedback from the MAC has resulted in meaningful changes, process reviews, and I think the members of the MAC can feel comfortable with the comments and the discussions that have been had, that we are definitely being heard, taken seriously, and the agencies are working as quickly as they can to try and resolve some of these concerns and issues. So I think it's a good discussion, and I'll just share that with you as information purposes for the members of the MAC and the public. Okay, next item on the agenda we have is the CMS household ex parte letter that was referenced. Whoops, we've got a comment. All right, yeah, we'll come back to that, Gina, in a little bit. Sorry. Good timing on the sun coming in here on me. I put on the agenda this next letter, CMS Household Ex Parte Review Letter. So I think we touched on this earlier. I'm going to see if I can share my
I have it ready,
screen.
Michael, if you want me to put it up.
Oh, well, that would be great. Thank you, Dory. So this was sent out in the meeting materials in preparation for the meeting. And this was a recent letter that went out to all state Medicaid directors, as was referenced earlier, asking them to explore some system challenges that may exist that CMS had heard about. And basically, if the eligibility systems in the different states were doing eligibility reviews at the household level instead of at the individual member level, that would result in a lot of inappropriate closures, because different categories of eligibility within the same household can have different income thresholds. And Jen and I had a chance to talk about this in our discussion preparing for the MAC meeting a few weeks ago. And Utah has reviewed its system and found that this is not an issue in the EREP system, that all of the eligibility determinations are done at the individual level, not at the household level. So while many states are struggling now, trying, in many states, the redetermination process has been put on hold until they get this programming completed. This is one issue we don't need to worry about here in Utah, because the system is programmed correctly, at least on that level, in terms of doing the determination on an individual level rather than a household level. And just earlier today, I saw CMS send out a report with all of the different states, those that weren't impacted or had the systems programmed correctly, and then the other states that had an impact, how many people they thought it had affected, and what the state's timelines were for trying to get a resolution. So if you're hearing about this, or you see it in some communications about additional systematic problems in eligibility determinations, I just wanted to make sure that people had a clear understanding that this is not one of the issues that, while it may exist in other parts of the country, is not affecting eligibility redeterminations here in Utah. So any questions on that? Okay, very good. All right, next we have on the agenda the MAC data request. So in about the middle of August, we had several questions come in from MAC members to submit to the department and ask them to comment, give us some feedback on that. And we got those back at the end of August, and we did distribute that to the members of the MAC, and we wanted to have time for a discussion about the data request and some of the specific questions or responses from the department, just to kind of work through that with the MAC. And I don't think this was actually sent out with the meeting materials either. So I was thinking I would try to share my screen on this. So let's see if that will work. All right. There we go. All right. So here are the questions that were submitted. And I will just open it up to members. Well, maybe just a quick review on different closure rates, timing of closures, process, were some of the themes involved in the data. As I was looking through the data, it said on this second question, let's see, maybe that's not it. I think it was one of these first questions where the department said they didn't have the data yet, but they would have it by about September the 8th. And I'm not seeing it right off. Maybe it's, I don't think it was this far down. So I will see if I can find that while I open it up to questions from the MAC in general or comments about what we saw in the data. Okay, and now that I'm sharing my screen, I can't see who's asking the question, so just go ahead, please.
Thanks, Michael. I didn't see anybody else jump in, so I guess I'll say I'm curious if the agency, if either of the agencies are surprised by the number or have an explanation for the number of individuals. If you go down to program type, like, you know, it looks like there's a lot of people that are on fixed income that are being disenrolled. And I don't know if Alan from AARP is here to know if that, it just seemed a little bit surprising to me when you look at like the aged, disabled, I don't know, some of those categories, you know, somewhat different question with like the TAM and the pregnant population groups. Like I would have thought that a number of those would be transitioned over into another program. I realize they might fall out of the category of TAM, but like, you know, I tried to ask around and I don't know if we have any like if we know about like, you know, what is to be expected as far as how many individuals within some of these different categories we would expect to see transition into another program. If there's any where like procedural disenrollments are particularly high in those program types. But I mean, I'm concerned about the numbers when it comes to like, and then of course, like the kids is alarming. But just seeing like, yeah, disabled, older, I mean, I don't know, their income, a lot of that is a lot of that population group is fixed income. So you wouldn't expect that they would have had significant income changes that would make it so that they no longer qualify. So I guess I'm just curious if the departments have anything to say about that.
I'll respond that we have begun investigating, Stephanie, some of these pieces you've called out to try to understand. And in fact, looking more closely at individual cases is one piece. Another area that we are looking is to actually solicit a survey of individuals who have closed to determine why they have closed. So that's another step we're taking as well. But I think diving into the data, which, takes some time, and, at least for the Medicaid side, Brian has really become our data expert in this area. He's been off for the last couple of weeks, taking a break. But we have looked at this data specifically in some of these populations to better understand, as we look at a case-by-case basis, what the disposition is. And I think Michelle's team is doing that work as well. We don't have any answers to share yet because we're still doing the work, but we're happy to share when we do have some outcomes that we've been able to look at. Michelle, do you have anything to add to that?
No, I think you've covered that really well, Jen. We are still in the process of working through that, and yes, we'll share that as soon as that's finalized. So,
Thank you. Appreciate that. And yeah, would be interested to hear that more. When I add up all these numbers, I don't know, somewhere around 100,000, I think. So I guess I just want to make sure I understand something, because I do appreciate a comment Lisa made earlier. I realize there are a lot of people that are bouncing back in, but my understanding, and I think I followed up and Brian did specify, these are people that were not just at the time this data was pulled, they were not re-enrolled. They were people that are just fallen off, and they weren't transitioned either, correct? These aren't,
That is correct.
the TAM
That is
closures
correct,
are.
Stephanie.
Okay.
At the time when this data was pulled, these individuals had not re-enrolled. That doesn't mean they haven't since re-enrolled, but when this data was pulled in August, I believe these were truly closed cases at that time.
Okay. Thank you.
Okay, so I found where I was finding the September 8th date. It's down here. Review results by each type of Medicaid program, and it says that you would have that data available by September 8th. So can you comment on, I guess, what data are now available as of September 8th, and you can share those with us?
Yeah, I'm going to punt this.
yeah,
to
Jen,
Maris.
did you want me?
Yeah, I was going to punt this to Maris if you could respond to this. I think this was a DWS data request, and I just want him to speak to the status.
That report is still being worked on. Unfortunately, limited resources and the amount of data that's requested for that is still being worked through. I think our timeline is to have this available by the end of the month, but I'll have to verify that date and be able to confirm it.
All right, great. So maybe we can discuss that in our next month's meeting as a possibility. Okay, and then back up to number 2. It looked like there was an attempt at validation of what we were asking for. So it said, question number 2, procedural closures with income data collected by SNAP, TANF, unemployment, and other programs that DWS collects income data on. And the response is DHHS and DWS will work to produce data on the number of procedural closures for Medicaid among individuals who had income data collected through a different program. Please confirm that this information would address your request, or let us know if there is other information you are seeking. So to me, I think that is the request. If DHHS and DWS have information, income information on an individual through another program, SNAP, TANF, unemployment, or other programs, then that's what the question is. But I'll open it up to members of the committee to see if they would like to add any clarifying comments to the question from the agency so they can get a response to number 2.
I know. Okay, I'll just say, I think I was one of the people, I think there are several of us that wanted this, but I think it's just are people moving up the economic ladder and that is why they no longer are eligible, right? And or like, is it like, I think it was just like trying to understand like what we know about their income status. So I don't know what that data, I don't know whether that would answer the question or not, because I don't have all of the, I don't know enough about like the data. That it doesn't make enough sense to me. That's just the question I think, at least that I had, but I think there were others. I think Rachel, I think there were several of us that wanted to know about that.
Okay.
We appreciate the clarification. As we looked at this question, we weren't certain, which is why we proposed the clarification response back. So thank you, Stephanie, for explaining context as well.
Right. Okay, any other comments or questions on this from the MAC members if you've had a chance to look through it? Just again, different levels of closures by ethnicity and race, aid category, gender, by language, and then by different rural and urban areas. So we thank the departments for putting together the information and the efforts to get the additional things clarified there. But if there aren't any questions, then we'll move on to the next item on our agenda, committee member updates. So this is just a chance for members of the committee to raise other issues that need some visibility for discussion with the Medicaid administration.
Is Cassidy on? I can't tell. Cassidy, if you're on, I don't know if you wanted to share any.
I hadn't seen him earlier, but let me just see.
I mean, he called me. I can share maybe a little. I mean,
He is not
called
on.
me in. Okay.
Myself,
I mean,
he's not on.
Okay.
There remain a lot of concerns within the Micronesian and Marshall Leaf community about eligibility and enrollment. Additionally, just concerns about whether or not it's so hard to understand the program. So I'll just explain like a question that he raised to me, which was that when a person, so he's like, I'm talking to different people who are all on Medicaid, but they all have different experiences about what they can get. He's like, so somebody can get dental, somebody else can't, somebody can go to this doctor, somebody else can't. It is really hard to like track, like, you know, and then like when I was trying to give him different phone numbers, he's like, you know, just keeping up with like all of the different like customer facing numbers. You know, I do appreciate, you know, Tracy and you know, people that are really helpful with constituent problems, but it is really hard to track like who does what. And so like, just will say, I think this has been brought up before, but like visual depictions of even just like how the program is managed would be like really helpful for people on the front lines to be able to share in their community of like, okay, DWS is housed for eligibility and, you know, HHS is this and the plans are this, right? Because like basically I had to break down like, okay, you've got Molina and like select like they just going through all of the things was like a lot. It actually is a lot to like try to process and then figure out like who is responsible for the problem that is happening. And so I just thought I would share. And then like the eligibility issues, I mean, hopefully we can get some specific cases for you all to review about what is going on with the Marshall Leaf Micronesian like eligibility issues, but that just remains. I think that the Pacific Islander rates were obviously a disparity, and I have heard from a number of people within the Pacific Islander community who really are like just kind of surprised by how many people around them are saying that they are showing up to clinics, pharmacies, et cetera, and they are not getting, and that's when they learn they're not covered. So anyway, I did want to just share that since I don't think Cassidy is able to be on today.
Okay. Thank you. Yeah, Jen? Go ahead.
Yeah, I'll just acknowledge, Stephanie, thank you for speaking on behalf of Cassidy. And this has been a conversation we've had before. Our public information officer is on the line today, and she's heard what you said. We will work on getting together a document. I know you wanted a quick, just a quick sheet that would help with customer service numbers. I like what you've also added around just the arrangement of the Medicaid program, DWS services as well. So it's a little bit of maybe an illustration for members so that they understand where they're navigating and who does what. So thank you for that feedback. And Colby and I have heard your request. Thank you.
Right. Okay, Dr. Baird.
Yeah, thank you, Dr. Baird, dentist on the MAC. Grateful for Prism. I mean, I know it's tough that we're all getting through it, and it's making good progress. I've had several dentists reach out to me. There's a couple issues, specific issues that need addressed with claims and things. Who can I reach out to work on those issues to make sure they're on the list, the bug list?
Dr. Baird, you're happy to reach out. You can reach out to myself. I can also give you the director of our operations office as well. Yeah. But let me, I can throw my contact info into the chat. Okay. But we're managing these issues daily, so we're happy to support you.
I know, and you're doing great, and I'm telling people just be patient. It's coming, but and you've made good progress. But
yeah, no, happy to help. My email is in the chat. Shoot me an email, and then I will share it with our operations folks who can help you with claims.
Thanks, Jennifer.
Yep, you're welcome.
Okay, any other topics to bring up before we go to the director's report? Okay, Jen, we'll let you squeeze in what you can in the next few minutes. Go ahead.
Okay, I'm going to talk fast. I'm going to give a high level. Nothing is really urgent, but I wanted one of the things that I had committed to do with Michael was to always present things in advance. So you had an opportunity and have visibility into the work that the Medicaid program is doing in other areas. Specifically, I wanted to spend some time on upcoming policy changes, just so you had awareness of these changes as they are as it is now almost the end of September. The first is a policy addition, and this is looking at the coverage of rapid whole genome sequencing, which is a genetic test administered to critically ill infants and children with an unknown diagnosis. This is a diagnostic tool that is helpful in guiding providers and understanding what an infant or critically ill child may have. Currently, it is a non-covered service. So effective November 1st, we will be opening these two codes to facilitate availability of whole genome sequencing testing for eligible individuals. So just a quick update on that policy, which is opening. Some exciting things I've mentioned before, but wanted to touch on again. We have lots of things happening in January, and wanted to just make sure that you had visibility to these as they are, as January is fast approaching. So I'll just go through and list these, but I'd like to spend a little more time on our state CHIP program. I've mentioned to you several times before that the Consolidated Appropriations Act, which came out at the end of 2022, did mandate that all states implement a 12-month continuous coverage program for children enrolled in Medicaid. We already have this in place for CHIP, but this this requirement now also applies to our Medicaid population. So this will go into effect on January 1st, 2024. The second piece is our non-traditional to traditional benefit change. So on January 1st, 2024, there will be changes so that any individual who is currently enrolled in a non-traditional benefit plan will have the same benefits as the traditional benefit plan. This was another CMS directive, and it was aimed at eliminating the disparities between the trad and the non-trad programs. Just to call out specifically what type of benefits the individuals who are now in a non-traditional program will receive by moving into a traditional program, they'll include things like non-emergency medical transportation. So it could be a UTA pass. So an individual may qualify for a UTA pass in order to ride public transportation. They may qualify to use our NEMT vendor if they live outside of our urban area. Also, it increases the number of visits that you can get for physical therapy or occupational therapy. Additionally, it opens up speech and audiology services and some durable medical equipment services as well. Also opens up the option of long-term care, and it allows also 19 and 20-year-olds who are currently enrolled in a non-traditional benefit to actually qualify for EPSIT level services or early and periodic screening, diagnostic, and treatment services. So we're updating our manuals and our policies and all of our systems to reflect that traditional benefit package for this group, and we're looking forward to that change. The next piece I wanted to spend just a little bit of time on was our new benefit around our what we're calling our state CHIP program. So during the 2023 legislative session, there was a bill, SB 217, which was called Children's Health Coverage Amendments, which allowed us to establish a new category of eligibility for individuals who meet the certain requirements. This program would qualify individuals for a CHIP program, and the requirements of this program are, first of all, it's a child who is a non-citizen, non-U.S. citizen, who is not a lawfully permanent resident. They are under the age of 19 and also meet income requirements of being under 200% of the FPL. You cannot be currently covered by other health insurance, not be receiving benefits through Medicaid or CHIP. And also the other important aspect of this is to be eligible, you have to be residing in the state of Utah for at least 180 days prior to that date of application. So what I'd like to share with you now is that this program will go live on January 1st in an open enrollment form. So at that point, we're able to open the benefit in the format of an open enrollment. This program did receive limited funding of $4.5 million, and it will run as a 3-year pilot. So we are going to be collecting data through the duration of this program to see what the results of utilization and the outcomes of the individuals served in the program are. Because it had a limited budget of that $4.5 million, we're going to be able to serve about 2,000 children through this benefit. So once the application process is full, we will stop in enrolling new applications at that time, and new ones will not be accepted until the next open enrollment period. So we're really excited about this new population. And what I've mentioned in the past is that we were preparing materials so that individuals, stakeholders, advocacy groups, those in our community could have awareness of this program. And we have actually loaded that on our CHIP website now. I think I'm only sharing a tab, so I can't flip and show you. But I want to show you, just share that we do have this now on our CHIP program. We have a really nice place at the bottom that says CHIP member update. And then if you see in this, it says coming in January 2024. There's also a hyperlink to frequently asked questions. And on that FAQ, which is intended to answer some commonly asked questions for our community that we will serve through this benefit, is what is state CHIP? Asking questions around the public charge rule, immigration status, so on and so forth. We will be having a Spanish version of this loaded on our website as well. At this point, we only have an English version, but it is available, and we'd love to have you access that website. The last piece I want to update with regard to a January 1st update is that we have received the opportunity to move forward with a full state plan benefit for 12 months postpartum coverage. So if you look under our waiver updates, Senate Bill 133 was what moved through our last legislative session, which was to allow individuals who are on the Medicaid program and CHIP program who are pregnant to move from a 60-day coverage or 2-month postpartum eligibility to move to 12 months postpartum eligibility. And so with this, what we've been able to do, the bill itself required that we applied for an 1115 waiver for a more limited population of individuals to receive this benefit. If the waiver were to be declined by CMS, we were able to move forward with a full state plan benefit. And in fact, it was declined, and we are moving forward with a full state plan benefit effective January 1st. I do have a couple additional updates, which are not incredibly time sensitive, Michael. So I will stop sharing now because it's the end of our meeting, but I will share my document with the committee for review.
Very helpful. Okay, thank you, Jen. We appreciate the updates and all of the good work and the presentations, the information you and Maris, DWS, and others have shared with us today. So with that, we will entertain a motion to adjourn until our next meeting in October.
Michael, this is Davis Moore. I'll do that motion to dismiss.
Very good. Thank you. And we have a second. I think we got a nod there from Dr. Brenton. We'll call that good. And if no one opposes, we will consider ourselves adjourned until next month. Thank you for your participation. Bye.